What I'd like to talk about for this hour are rare but still important thyroid lesions. As a pathologist, it's not only our responsibility to know the most common entities, but it's also our responsibility to also know those zebras and unicorns out there, and that oftentimes we're on the front lines when when somebody is asked to make a rare and difficult diagnosis. So even though we might not see these thyroid lesions as commonly as the ones that I presented in the last hour, they're always good to think about just so we don't miss that occasional but critical case when it comes along. I do not have anything to disclose. So in terms of objectives for this talk today, I want to discuss rare but important thyroid lesions, and basically I'll go through some of these lesions and talk about the specific histologic criteria that we use to make the diagnosis of these lesions. I also want to talk about the histologic variants of some of these lesions, as well as key differential diagnoses to consider. I also want to talk a little bit about the relevant ancillary studies that we utilize when making the diagnosis of these thyroid lesions. So one of the rare thyroid lesions that's always good to think about is medullary thyroid carcinoma. Oftentimes, depending on the size of the practice, you might encounter these maybe once or twice a year. However, it's critical for both the patient and the clinician for us to recognize medullary thyroid carcinoma, and it can sometimes be particularly tricky in that these are known as the great mimicker of thyroid malignancies. They usually occur in about 3 to 4% of thyroid malignancies. Most cases are sporadic, but they can be familial in 15 to 30% of cases. And medullary thyroid carcinomas that are familial, usually the patients will present at a younger age, and these are autosomal dominant. And so there's multiple syndromes that are associated with medullary thyroid carcinoma. The men syndromes will both present with medullary carcinoma, the men too, as well as familial medullary thyroid carcinoma. So in terms of clinical presentation, these typically will present as a painless solitary nodule. Again, if they're not familial, they'll present a little bit older in life, so between the 5th and 6th decade of life. And sometimes the patient will present with a hoarseness or stridor or dysphagia from compression of the adjacent anatomic structures. At presentation, approximately 50% will have metastases, and some patients can have paraneoplastic syndromes from hormones being secreted by the medullary thyroid carcinoma, and these paraneoplastic syndromes can include diarrhea or rarely Cushing syndrome from ACTH secreted by the medullary thyroid carcinoma. So in terms of gross examination, these can range in size. Microcarcinomas can be less than 1 centimeters, but these can also be very large in size, over 6 or 7 centimeters. And they're often found in the mid-lateral lobes, which is predictable because that's anatomically been found to be the area in the thyroid where you have the highest density of C cells, which is the cell of origin for medullary thyroid carcinoma. They can be bilateral, particularly if the patient has one of the hereditary syndromes I mentioned before. So in terms of microscopic appearance, one of the difficulties with medullary thyroid carcinoma is the fact that they can vary so dramatically in terms of the microscopic appearance. Generally, in terms of the general appearance, usually have sheets and nests of cells which do not really form a follicular architecture because, again, these are not composed of the follicular cell, the thyroid. Instead, you'll tend to see sheets and nests of cells that are separated by stroma, and these can be in various architectural patterns. They can be in a trabecular architectural pattern, insular architectural pattern, or a linear architectural pattern. And then when you go down and look at the cells, generally the cells can be round or oval, or they can even be spindled, and the nuclei have relatively fine chromatin, a very fine chromatin pattern similar to neuroendocrine cells in other anatomic sites. Generally, the cytoplasm is amphiphilic, and there can be varying amounts of background fibrous stroma of variable thickness. Calcifications can be present. And as many of us know, you can have associated amyloid with these lesions, and it's thought that the amyloid is likely secondary to calcitonin secretion by the neoplastic cells. Usually the neoplasm looks relatively bland in that you usually have rare mitoses, And importantly, it's important to know that you can have intranuclear cytoplasmic pseudo-inclusions, which that can be a real problem in terms of mimicking a papillary thyroid carcinoma. Less common features that can be associated with the medullary thyroid carcinomas are mucin production or clear cytoplasm. But again, these are less common, but good to be aware of. You can also have focal calcifications, and if it's less than 1 centimeter, these are termed medullary microcarcinomas. So this is a very low power appearance of a medullary thyroid carcinoma, and so what you can appreciate at low power is you have various amount of fibrous deposition along with amyloid deposition here, and you don't really see any real follicular architecture. You just see sheets and packets of cells in a nodular or trabecular pattern here. You go down further, and again, you see a very monotonous monomorphic cell population that's distributed in solid sheets or nests here. And even higher power, you can begin to appreciate the fine chromatin pattern as well as the amphiphilic cytoplasm. The nuclei are either round or ovoid in shape, and there is a little bit of a vague sort of spindling or at least a streaming of some of the cells present when you go down on higher power here. Again, just showing the varying fibrous septae and the various architectural patterns here. And then, of course, with this medullary thyroid carcinoma, we have our amyloid deposition here, as shown by these opaque, waxy, eosinophilic depositions in close proximity to the neoplastic cells here. In terms of microscopic variants, you can have various microscopic variants, including oncocytic variants. So just like any other neoplasm, oncocytic cytoplasm doesn't necessarily exclude a medullary thyroid carcinoma. In terms of what will help, staining for calcitonin will be very helpful in terms of differentiating this from the oncocytic variants that we talked about before of papillary thyroid carcinoma or oncocytic variant of follicular carcinoma. There could also be what's called a glandular variant, and that can be particularly tricky because, as I noted before, medullary thyroid carcinomas are not composed of the follicular cell; they're composed of the C cell. And so this can be tricky in that if you see these tubular structures, you might mistake this for follicular architecture and mistake this for follicular neoplasm. Even more tricky is that sometimes these tubular structures can have a colloid-like material. It's actually not colloid. It's thought possibly to be calcitonin deposition that's just mimicking colloid. So, again, if something doesn't look quite right, don't hesitate to do immunostains to further work it up. You can also have a papillary variant, and really what this is almost a pseudopapillary architecture that results from cell dropout of the medullary thyroid carcinoma and basically leaves a pseudopapillary-like architecture. Again, numerous other variants, so spindle cell variant, where it's essentially entirely composed of spindle cells, have squamous cell variant, clear cell, small cell, paraganglioma variant, giant cell variant, melanin-producing variant, angiosarcoma-like variant. So again, you can see that medullary thyroid carcinoma truly earns its name as the great mimicker of thyroid malignancies. In terms of immunohistochemistry, the good news is that even though medullary thyroid carcinoma can mimic all these different types of morphologies, it has a relatively specific staining pattern in that it's positive for neuroendocrine markers, specifically synaptophysin and chromogranin, and it's also positive for calcitonin, although this staining can be somewhat variable. Other peptides can be positive, and as I mentioned before, medullary thyroid carcinomas can sometimes cause paraneoplastic syndromes by secretion of some of these peptides. So it can secrete ACTH, for example, and elicit a Cushing's type syndrome. It can also secrete insulin or gastric-releasing peptide, somatostatin or glucagon as well. In terms of molecular studies, medullary thyroid carcinomas have been found to be associated with a gain of function in the RET gene, and that encodes for tyrosine kinase. So sporadic medullary thyroid carcinoma you'll also see somatic RET mutations in about 30 to 66% of cases. And this can be helpful clinically because it's been shown that cases that do have this somatic RET mutation have a higher frequency of metastases, both to the lymph nodes as well as distal metastases. And so molecular studies can be useful for establishing a germline mutation such This can also help elicit whether or not this patient's family might have a familial syndrome associated with medullary thyroid carcinoma. So what's often done is when a patient is diagnosed with medullary thyroid carcinoma, the peripheral blood can be drawn to evaluate for a RET mutation. And then once this location of the mutation is identified, the family members can then be tested to see whether or not they could possibly be at risk for medullary thyroid carcinoma, and then get possible prophylactic management as needed or indicated. In terms of a differential of medullary thyroid carcinoma, the first thing to think about would be C-cell hyperplasia. As I mentioned, medullary thyroid carcinoma, the cell of origin are the C cells of the thyroid. And generally, the criteria that's been proposed is that if you have greater than 50 C cells per 10 high powered field, that would be the cutoff between C-cell hyperplasia and medullary microcarcinoma. But admittedly, this is somewhat of an arbitrary designation. Others will look, and you can look at the growth of these C cells and see, are they infiltrating into the adjacent parenchyma? Do they show an infiltrative pattern? Or do they have associated fibrosis, which might indicate a destructive growth pattern? And this can also help you differentiate between a C-cell hyperplasia and a very small or a micro medullary carcinoma. Other things that would be in the differential, of course, would be papillary carcinoma. I mentioned that both can have these intranuclear cytoplasmic pseudoinclusions. And then also medullary can also have the pseudopapillary architecture. Again, what's helpful, of course, is that you're dealing with two different cells of origin, so you can use your immunostains to stain the synaptophysin, chromogranin, calcitonin associated with medullary carcinoma, and of course, papillary carcinoma will not show that staining as it is of a follicular cell origin. Follicular carcinoma, both follicular carcinoma and medullary carcinoma can have somewhat of a solid pattern or solid architecture, which can sometimes cause some diagnostic confusion. As I mentioned before, medullary carcinoma can also have this glandular variant or tubular variant, where you have this intratubular material, most likely calcitonin, that can mimic colloids. So again, you just want to be aware of that, and don't hesitate to do immunostains when needed. Poorly differentiated carcinoma, or what some people call insular carcinoma of the thyroid, again, can have similar architectural features in that you've lost your follicular architecture, and then you have this trabecular or solid arrangement of follicular cells. The calcitonin and immunostains will also help you discriminate on those as well. And then sometimes anaplastic carcinoma will come in the differential, and the reason being is that medullary carcinoma will oftentimes have, or can sometimes have, a predominant spindle cell appearance. And so with this spindle cell appearance, this is also one of the patterns you associate with anaplastic carcinoma, which is a very aggressive neoplasm. And so it's very critical to make that differentiation, because anaplastic carcinoma just has an abysmal prognosis. So you definitely want to have a low threshold if those are two entities that are in your differential. Again, neuroendocrine markers and calcitonin can be helpful in that. In terms of treatment, these are generally treated more aggressively than the other more common thyroid malignancies, such as papillary thyroid carcinoma or follicular carcinoma of the thyroid. So generally they receive a total thyroidectomy and a central neck dissection, and then they'll possibly get an ipsilateral modified radical neck dissection. So there are treatment implications in terms of being able to diagnose this correctly. And then, of course, there's an issue of evaluating the patient for familial syndromes associated with medullary thyroid carcinoma, and then possibly offering a prophylactic thyroidectomy to family members. In terms of postoperative treatment, that's variable. Some receive external RT, radioiodine therapy, radiofrequency ablation. There's also potential for RET-directed therapy in the future. Again, this is a tyrosine kinase inhibitor, so that always that shows potential promise in terms of more molecular targeted therapy. Also, prophylactic thyroidectomy, as I mentioned before, can be offered to family members who are shown to have germline mutation. So the next entity that I want to talk about is poorly differentiated carcinoma, or what some people call insular carcinoma of the thyroid. And these are aggressive malignancies, and it's probably best to think of these as sort of the in-between stage between your conventional carcinomas, like your follicular or papillary thyroid carcinomas, and it's sort of an intermediary between that and then the really aggressive carcinoma, which would be anaplastic carcinoma of the thyroid. So this is sort of an intermediary between these two stages or these two extremes of thyroid malignancies. In poorly differentiated carcinoma, really the signature feature is that you really begin to lose the morphologic features of follicular cells in the thyroid. These occur relatively rarely, less than 1% of thyroid malignancies. Patients tend to present older in life, so between 5 to 6 decades. And a lot of times these will evolve from a pre-existing malignancy. So you can think of it as a progressive process where you're starting out with a follicular or papillary carcinoma, and then that then eventually will, when a certain percentage would then potentially evolve into a poorly differentiated carcinoma over time. That being said, these can also just skip straight to poorly differentiated carcinoma without first having a pre-existing lower grade carcinoma. In terms of prognoses, about 50% will have metastases at diagnosis, so that these behave more aggressively. And extrathyroidal extension or lymph node metastases can indicate a more aggressive prognosis. In terms of presentation, often what will happen is patients will have this thyroid mass, which will then begin to drastically increase in size more rapidly than was initially thought. And again, that would be compatible with having a pre-existing malignancy, which then moves into a higher grade behavior, such the higher grade behavior of poorly differentiated carcinoma. In terms of microscopic features, again, you really lose your follicular differentiation here. So you move into a solid or insular or trabecular architecture. Importantly, as part of the criteria, because you lose those features, you should also, if you have a pre-existing papillary carcinoma present, you should see a loss of the nuclear features of papillary carcinoma. So in other words, you don't see the vacuolated nuclei or the pseudo-inclusions of papillary carcinoma. Instead, you essentially de-differentiate into just cells that lose that papillary carcinoma-like cytologic appearance. Additionally, in addition to these two criteria, you need to also see one of the following. So you need to either see convoluted nuclei or tumor necrosis in at least a group of cells, or increased mitosis, which is defined as 3 or more per 10 high power fields. So this is a section here, a poorly differentiated carcinoma, and you begin to lose your follicular architecture here. And then you can see here that you begin to have these areas of necrosis here, and you don't see any sort of vesicular nuclei or any nuclear features that would look like a papillary thyroid carcinoma. Again, here you do not see the papillary thyroid carcinoma-like features. The nuclei are relatively bland, but again, you shouldn't see this type of areas of necrosis present throughout the malignancy. In terms of immunohistochemistry, again, because these are follicular in origin, you generally will see diffuse positivity of TTF1 still present, even though you're beginning to lose that differentiation. Although with thyroglobulin, which is a cytoplasmic stain, you might only see focal thyroglobulin staining in these. PAX8, which again is a nuclear stain for follicular cells of the thyroid, that should be present. And AE1, A3, CK7 should be strong and diffuse. Your Ki67 staining will be mildly increased or moderately increased at about 10 to 30%, which can indicate, again, that you're dealing with a proliferative activity. In terms of differential, follicular carcinoma would be in the differential, but you really shouldn't have significant mitoses or necrosis present. That being said, it is good to be aware that follicular carcinomas can have areas of a solid architecture, which would make you think of insular carcinoma. But again, when you go down, you don't see the mitoses or the necrosis that's associated with a poorly differentiated thyroid carcinoma. In terms of papillary thyroid carcinoma, like I said before, you really shouldn't see the nuclear features of that in order to make the diagnosis of a poorly differentiated thyroid carcinoma. Medullary thyroid carcinoma, again, this would come up sometimes because they both lack a follicular architecture, and immunohistochemical stains can help you differentiate between these two entities, as I mentioned before. And then anaplastic carcinoma. can come up in the differential, which of course, since you're dealing with a progression from stage to stage in terms of degree of malignancy, it's not unnatural to ask yourself, well, could you go all the way to anaplastic carcinoma? In terms of evaluating between these two lesions, it's important to realize that with anaplastic carcinoma, you're generally going to see more nuclear atypia, and you're going to see usually a greater amount of necrosis. So you're not just going to see, areas of necrosis. You're going to see more diffuse. It's just going to be much more diffuse in terms of the amount of necrosis that you see. Usually with anaplastic carcinoma as well, the immunohistochemistry can sometimes be telling in that you generally will lose TTF1 and thyroglobulin, although you can retain the PAX8 immunostaining in the nuclei. So the immunohistochemistry, you lose that immunohistochemical differentiation that you might otherwise appreciate in the poorly differentiated carcinoma of the thyroid. In terms of prognosis, again, the prognosis is between well-differentiated neoplasm of the thyroid, like papillary thyroid carcinoma and anaplastic thyroid carcinoma. So you have about a 5-year survival of about 65%, and then a 10-year survival of about 35%. In terms of treatment, there's really not a very consistent treatment regimen. Total thyroidectomy and lymph node dissection, many advocate radioactive iodine, and then potentially external beam RT if they're higher stage tumors. And then the big one is anaplastic thyroid carcinoma. And so, oftentimes we associate thyroid malignancies with a relatively good prognosis. However, that being said, anaplastic thyroid carcinoma is really not within that paradigm. It's a very aggressive thyroid malignancy, and oftentimes just can be seen as just having an abysmal prognosis. Thankfully, these are rare malignancies, and so it's not a diagnosis that you really would expect to make that often, and it's really a diagnosis that really needs to be made very carefully because of the prognostic and clinical implications for the patient. Goiter is a risk factor for this, and again, many will originate from an existing malignancy, which then will progress, which that keeps in line with what we were talking about with poorly differentiated thyroid carcinoma, and that there's a spectrum that often takes place. Now, that being said, just like poorly differentiated carcinoma of the thyroid, you can go straight from a goiter straight to an anaplastic thyroid carcinoma, so it would not exclude that pathway at all. In terms of your demographics, generally it often originates in older adults than what you would expect for your more differentiated thyroid carcinomas. Like I said before, often these will arise in a pre-existing thyroid malignancy, but they can also arise from a pre-existing benign process, such as a goiter. Iodine deficiency is a risk factor, as well as radiation exposure, which is very similar to the other risk factors that we've discussed before in terms of thyroid malignancies. In terms of the clinical presentation, so when diagnosing this, I would really emphasize that you really want to talk to the clinician to make sure that this clinically fits before you make this grave diagnosis. So oftentimes it's good to call your clinician, either the endocrinologist or your surgeon, and ask them, how does this patient present? Because usually they're going to tell you the presentation is relatively rapid in onset, as opposed to what you would associate with other more differentiated thyroid malignancies, which tend to be more indolent in terms of growth. And so basically these malignancies are more aggressive clinically, and oftentimes can replace the thyroid gland grossly. Oftentimes they often extend into the soft tissue, and about half will show extrathyroidal extension. As I said before, they often replace the thyroid gland. And then microscopically, anaplastic thyroid carcinoma, microscopically they all share patterns that you would associate with an aggressive malignancy. So significant amounts of mitoses, nuclear pleomorphism, showing irregular nuclei with a coarse chromatin pattern, as well as extensive necrosis. In terms of microscopic patterns, there are sort of variations in terms of the microscopic patterns, and it's good to be aware of these just so that you don't make a misdiagnosis. So there is a spindle cell-like pattern in which you really lose you begin to lose like an epithelial sort of appearance that you would associate with thyroid malignancies, and it almost becomes fibrosarcoma or MFH-like in terms of the appearance. And so just be aware that even though you have a spindle cell lesion, anaplastic thyroid carcinoma is certainly in the differential. You can also have a squamoid non-keratinizing type microscopic pattern. And then you can have a microscopic pattern which is accentuated or apparently shows numerous pleomorphic giant cells. And these giant cells appear to be malignant giant cells in that they have multiple hyperchromatic nuclei. You can also have rhabdoid cells. And it's important to know that you can have hypocellular anaplastic thyroid carcinoma. So just because you don't have significant amounts of cellularity doesn't necessarily exclude an anaplastic thyroid carcinoma. And sometimes these can be mistaken, these hypocellular lesions can be mistaken for other more fibrotic processes, such as a Reidel Thyroiditis or possibly a burned out or chronic Hashimoto's thyroiditis. So it's just important to always be vigilant to pick up highly atypical cells, which might not be as apparent in these type of microscopic pattern. So this is a microphotograph of anaplastic thyroid carcinoma. You see benign thyroid follicles here, and then you see this dense neoplastic cell population, which effectively effaces the thyroid parenchyma here. And again, you have these innocent bystanders, these follicles here, and then it's just infiltrated by this dense malignant cell population here, which you almost wonder, is it epithelioid in nature, or could it be possibly even almost sarcomatoid in nature, and just really loses differentiation. Here you have significant areas of geographic type necrosis, so you're not just seeing the focal necrosis we talked about before in poorly differentiated thyroid carcinoma. You're seeing basically sheets of geographic type tumor necrosis. Again, here, anaplastic thyroid carcinoma, you have spindle-like cells, highly atypical, pleomorphic nuclei of varying shape and size, as well as mitoses present. In terms of immunohistochemistry, this can be difficult because at this point you've lost so much differentiation in this thyroid malignancy that the negative markers don't necessarily exclude it. You can't, generally over 80% will stain A1, A3, but this can be focal and weak, so you have to be very vigilant when you do the stains in terms of what you're considering to be negative. The spindle cell morphology is the least likely to stain, which it's not really surprising if you think about it. EMAs are even less sensitive. TTF1 is rarely expressed. The one immunostain that can be helpful in terms of eliciting the tumor as being of thyroid origin will be PAX8, and those have been shown to be positive in approximately 80% of anaplastic carcinomas, so that can be helpful. Ki67 is a positive, or your Ki67 proliferation index is even more increased from that of a poorly differentiated carcinoma, in that it's about 50%. So in terms of the differential, poorly differentiated thyroid carcinoma would be in the differential. Again, there's a significant prognostic difference, so it's definitely something that you want to make with care in terms of where you place your diagnoses. Anaplastic is going to generally show more nuclear pleomorphism, and you're going to see more necrosis. TTF1 can sometimes be helpful in that it's usually not expressed in anaplastic as opposed to being retained for expression in poorly differentiated thyroid carcinoma. And then the other thing, of course, would be as I mentioned before, Reidel Thyroiditis can be, oddly enough, even though that's not a malignant entity, sometimes that you can mistake a paucicellular anaplastic thyroid carcinoma for a Reidel Thyroiditis, just given the limited cellularity that's seen there. TP53 will highlight anaplastic cells, and again, just being vigilant for those atypical cells in a fibrous stroma can be helpful in terms of differentiating that. Another thing to keep in mind would be medullary thyroid carcinomas, and I mentioned before, medullary thyroid carcinomas can be diffusely spindled in terms of the morphology, so sometimes that can be problematic in terms of trying to differentiate the two, but thankfully, again, you can use immunostains to differentiate the cell of origin, and be particularly careful if you're going to make a diagnosis of anaplastic carcinoma if the patient has a history of a familial syndrome associated with medullary thyroid carcinoma. Molecular could be potentially helpful in that medullary has a RET mutation, whereas anaplastic is usually associated with BRAF, RAS, and RET PTC. So the next entity I want to talk about is hyalinizing trabecular tumor. And this is a rare thyroid tumor, but again, it's good to be aware of because if you're not careful, you can sometimes mistake this for a more malignant entity in the thyroid, particularly a papillary thyroid carcinoma. These occur predominantly in female patients and can be associated with lymphocytic thyroiditis or goiter. These present as a palpable nodule similar to other thyroid lesions that we've talked about before. Again, they can be instantly found on a goiter resection and, or could present as a palpable nodule. In terms of the microscopic examination, these are generally well circumscribed, and the cells are arranged in a trabecular-like pattern, and they have a vaguely fusiform-like appearance. And the background stroma, what's unique about these lesions is that they show a hyalinized background, and there's really minimal colloid present. What's tricky about these entities is that they have grooves and intranuclear cytoplasmic pseudoinclusions. So then the question, can come up: well, are you dealing with this entity, a hyalinizing trabecular tumor, or are you dealing with a papillary thyroid carcinoma? And so that can be the problem in terms of making this diagnosis. In the cytoplasm, they will show sometimes some yellow cytoplasmic granules, which can give you a hint in terms of this entity. You can also see background inflammation or hypertrophy. So this is a hyalinizing trabecular tumor here, and really the first thing that should come out to you at low power is that instead of the usual background thyroid parenchyma or even the supporting thyroid stroma, you see a very dense hyalinization, which is intimately associated with the cells in this lesion. If you go down, again, it's just really closely associated with the cells in this lesion. And the cells can show a fusiform-like appearance in which you have sort of these elongated nuclei that really aren't overlapping so much as they're just kind of sometimes growing in sort of a vaguely parallel direction. Again, just showing the fusiform-like appearance with the associated hyalinization of the background stroma. So in terms of immunohistochemistry, these are follicular in origin, so they'll be positive for TTF1 and thyroglobulin, negative for calcitonin. And again, the negative for calcitonin is helpful in that sometimes you can mistake that hyalinization for amyloid deposition of a medullary thyroid carcinoma, so don't hesitate to do that. Interestingly enough, these on a Ki67 stain, on a particular clone of the Ki67 stain, these can show a unique staining in that they have a membranous or peripheral cytoplasmic staining. And if you remember, Ki67 is usually a nuclear stain, which is usually used to indicate a proliferation rate. However, with this particular entity, they show this unique staining pattern, which can be very helpful in terms of differentiating this from something like papillary thyroid carcinoma. With papillary thyroid carcinoma, again, you'll have grooves and intranuclear cytoplasmic pseudoinclusions, which you can also see in this entity. It's not particularly helpful, but in hyalinizing trabecular tumors, you will see this background hyalinization and these yellow granules, which can be helpful. Again, the Ki67 stain can also be useful as well. Follicular adenoma can be in the differential. These usually will contain more bland-appearing nuclei, and they don't usually have the atypical nuclear features. And again, they usually lack this unique Ki67 staining pattern as well as the hyalinization pattern. Medullary thyroid carcinoma, as I mentioned before, the hyalinization can sometimes be mistaken for amyloid deposition. So, just have a low threshold for doing immunostains, which can easily help you differentiate between these two entities. And then in terms of molecular studies, it's a little bit controversial. There's a report of seeing a RET-PTC translocation, which, if you remember, has been associated with a certain proportion of papillary thyroid carcinomas. However, it's really still unclear whether or not that's really a signature translocation that's associated with this entity, in that the report was really not a quantitative study. And so it still remains to be seen whether or not that's a legitimate translocation associated with a hyalinizing trabecular tumor. These are negative for BRAF, which again is a mutation you see associated with papillary thyroid carcinomas, and also negative for RAS as well. In terms of the prognosis, extremely low malignant potential, and a lobectomy is generally curative. So again, there is clinical value in differentiating this from papillary thyroid carcinoma, which oftentimes will lead to a completion thyroidectomy, whereas this, you can save the patient from having to go on to medical thyroxine treatment. The other thing that really is important to keep in mind, which I think sometimes we can often dismiss, is metastasis to the thyroid. And oftentimes, we really don't see that often, and so we don't think about it as much. But, if you do have a mass in the thyroid gland and the patient does have a history of malignancy, which again is becoming more common because we are seeing more common scenarios here where the patient's being staged for some other cancer, and then we see this mass in the thyroid gland. So it's becoming more and more important to have the clinical history and just to be aware of the patient's previous malignancy history whenever you're evaluating thyroid lesions. These metastases, they can be solitary or multiple nodules, so that's not necessarily going to exclude metastases. In terms of microscopic, of course, it's going to vary depending on what the tumor is that's metastasizing to the thyroid. And generally, it would be distinct from the thyroid parenchyma. Common sources are kidney, and it's something people usually like to talk about, and is that you can have a conventional clear cell type renal cell carcinoma is particularly associated with metastases to the thyroid. So just be aware of that. And then also common malignancies, other common malignancies like lung or breast can also be metastatic to the thyroid as well. So this is a picture of a metastatic renal cell carcinoma. So here you have your usual thyroid parenchyma on this side, and then on the other side here you have conventional renal cell carcinoma. And just showing a closer, again, you have this renal cell carcinoma clear cell type. So, before you try and get fancy and start thinking of clear cell variants of whatever thyroid malignancy that you might be suspecting, always just keep in mind that this could represent a metastases, and just make sure to have the appropriate clinical history whenever you're seeing these atypical appearances of thyroid nodules. Again, in terms of finding the primary, so immunostains can help you determine if something is follicular or not in origin. So TTF1, thyroglobulin, PAX8, CK7 can be valuable. Of course, TTF1 is not specific for thyroid. It also stains for lung, and then you can also see some staining in other malignancies as well. Same thing for PAX8. It's certainly not specific for thyroid, and of course will also stain for renal malignancies. So obviously, just like every other site, you want to use your immunohistochemistry with an appropriate knowledge of what you're looking for and what you're going to do with the results. And then, of course, synaptophysin chromogranin can be helpful in terms of evaluating whether or not something can be of C-cell origin. But again, it's critical that the clinical history is there. Differential clear cell variant of follicular adenoma can be confused with renal cell carcinoma, as I mentioned before in previous lectures. But there are markers that can help you differentiate that, namely CD10, RCC antigen, and so forth. Also, RCC usually has more of a vascular pattern, just with the VEGF upregulation with renal cell carcinoma. So that has more of a delicate vascular pattern associated than you would probably see with a follicular adenoma. And then another thing to keep in mind would be that you can have a primary squamous cell carcinoma of the thyroid, and so if you're dealing with squamous cell carcinoma in the thyroid, you have to consider that as a potential primary versus metastases or direct extension. And again, the clinical history is probably going to be the most helpful in terms of making that determination. So in terms of summary, there certainly are rare entities of the thyroid out there, but they do have to occur somewhere. And so being aware of these entities whenever you're making your everyday diagnoses in thyroid pathology is critical. Because if you're not thinking about it, you're not going to be able to make the diagnoses when it actually comes along. And because these rare malignancies do have different treatments and substantially different prognoses in certain entities, it's important that we make these correct diagnoses in a correct manner. Ancillary studies can be helpful, but like any other area of pathology, it's important to do that in the appropriate clinical and morphologic context.